every Friday we have a Health Friday conversation. And today we're having one about hospice and what hospice is, how it helps us, what it means. And for that reason, we are joined by two doctors in the studio. One of them is Dr. Esther Muinga. She's a special coordinator for pain relief and palliative care. And Dr. Esther Nafula. She is a palliative care and pain management specialist at the Kenyatta National Hospital. Good morning, Dr. Esther and Dr. Esther.
Good morning.
Karibuni sana. For purposes of this conversation, we've agreed before we went on air that Dr. Esther Nafula will be referred to as Nafula and Dr. Esther Muinga will be referred to as Esther. Sawa. Now we know. How are you, Nafula?
I'm fine, thank you.
Very well. Welcome to Kenya's biggest conversation.
Thank you.
Karibu sana. And Dr. Esther, how are you?
Very well.
She's in KNH. Where are you?
KEPCA. It's called KEPCA.
What is that?
KEPCA is Kenya Hospices and Palliative Care Association, which is an NGO that coordinates palliative care services in Kenya. So working closely with people like Nafula at KNH.
So the H is silent somewhere in that KEPCA?
Yes, it's silent.
The Kenyan Hospices and Palliative Care Association. Where is the H?
Hospice is not a hospital.
Okay. Karibu sana. To welcome you to the show, CT has the day's proverb.
Yes, our proverbs for the whole of this week have been from the country of Malawi, whose commercial capital is?
I keep forgetting.
Because the B.
Blantyre.
And whose administrative capital is?
Lilongwe.
Yes.
Okay.
Coming to Kenya, which is our administrative capital?
Nairobi.
Commercial capital?
Nairobi.
How dull. Okay.
You know,
That's at least.
we need to have Isiolo as a capital of something.
It would help tremendously, wouldn't it?
Okay.
A piece of incense may be as large as the knee. This is the proverb, by the way. I'm not just making a statement. I'm reading the proverb. A piece of incense may be as large as the knee, but unless burnt, emits no fragrance.
Dr. Esther, what do you make of that proverb? What's your interpretation of it?
Nice proverb.
Yeah, it's a nice proverb. We all agree, yes. What? So now?
Incense, unless you burn it, you never get its full benefit. So unless you activate or do something. So for this case, just lighting the fire makes the incense functional. Yeah.
Dr. Nafula, you sound like you're escaping and you cannot use the same answer that's been given before. Your interpretation must be unique to you.
So, how I understand that proverb is that, incense can be something big, but unless you burn that incense, you will not get the benefits or the fragrance. So, for any activity, whether it is big or small, it's the impact that matters.
Right. Good
How many
one,
points
City.
do you have to give today,
City?
5,000?
No. Actually, it's 10 out of 10 because we asked for their opinions and that's what they've given us, their opinions. Yes. With proverbs and interpretation, you can't be wrong. Yes. Even if you took the proverb somewhere else and say, when a camel walks backwards, and I'd say, that's your interpretation. Fine.
Okay. Dr. Nafula,
Yes.
what is palliative care and how is it different from pain management?
Okay, palliative care, if I was to define it, I would call it to be the interventions that are given to a patient and a family as they're going through problems that are associated with a chronic, life-threatening or life-limiting illness. So chronic illnesses are those that require patients to be in and out of hospital. They get a lot of care. And they need a lot of support from the hospital, from the family, from the society. Life-threatening illnesses are illnesses that can be cured, but sometimes they become fatal, like COVID. Then we have life-limiting illnesses. Those are illnesses that are likely to progress and get worse with time. So when we give patients palliative care, we focus not just on their physical problems, that you've come with pain, We also look at how is this illness impacting your psychology, how is it impacting your family life, how is it impacting your work, what are you thinking about it in the spiritual domain. So what kind of support can we actually give to this individual and their family so that they can be able to cope with that illness and the changes that come with the illness. So pain management would be basically just focusing on pain. So you have pain, where is your pain? How is this pain making you feel about yourself? How is it impacting your activities? So it would be focused just on pain. But palliative care deals with pain and other symptoms that come along with an illness.
You've studied medicine.
Yes.
You become a doctor. Now, what do you need to study to become a pain specialist?
You need to study pain management for a couple of years more. After medical school, you'll go through intensive pain training that could last anywhere from 1 year to 4 years.
Okay, what is it called? We know OBGYN,
Yes.
we know pediatrics, we know internal medicine.
Cardiology.
We know
It's
those
called
ones.
pain
It's called
management.
pain.
It's just pain
Yes,
management. That's what it's
yes,
called.
Yes.
Connie, those 7 years when you
Yeah.
were doing the Bachelor of Surgery and Medicine, you didn't deal with pain?
Just a little bit. So when you go
7
into-
years, a little bit of pain. And you're
There's a lot.
studying to be a doctor.
You see, there's a lot to study to become a doctor.
No wonder the
so
other
now
doctors
when
are
you
like that.
specialize when you specialize in pain management, you go into now details. You just focus on pain as a disease, not just as a symptom. But how do you treat pain? How do you manage pain? What is pain? So there's really more to it than what is taught in undergraduate.
Dr. Nafula, talk a little bit more about this.
Yes.
Pain as a disease. What do you mean? Because we've
yes.
grown up to believe pain is a symptom.
Yes.
But now as a disease, what is this?
So pain is considered a symptom, as
Yes.
you've rightly said. So it usually points out to an underlying problem. But in many cases, patients with chronic pain, you find that they have a disease that cannot be cured, that is resulting in pain.
Chronic meaning
More than 3 months.
So it's
You've
continuous.
had pain, yes.
it's just continuing
continuous.
3 months. It's not stopping.
Yes.
Okay.
And you might get interventions for the pain, but they're not working. That means someone is taking painkillers, the pain is not going away. So sometimes there might be an underlying cause of the pain that we can treat. We might be unable to treat, or some patients just come with what we call a complex pain. You might not really isolate and say this is the cause of pain, but yet you still have to manage the pain. So you still have to ensure that your patient is comfortable and able to go on with their daily activities. If they want to go to work, they're able to do that. But yet there is pain that they have to live with.
Okay.
Yeah, so when we do pain management, we focus not just on painkillers, but on the holistic nature or on the whole person. So this, when you have chronic pain, you will not go to work. You might not be able to function at home.
Yeah.
You might be spending a lot of time just locked up in your room thinking about the pain. So how do we support you more than just giving pain medications?
Where? Okay. Dr. Esther. So what is a hospice?
Hospice, it's not where you throw away patients.
You heard him. Huh?
Yeah.
I did not say throw away. This man was talking about this place
Warehousing
where
patients.
you keep old people. That's what I refer to as the warehouse. Yes.
So a hospice is basically a terminology that talks about a place where you're taking care of patients. So it's not really a building, it's just a philosophy of care where you're caring for their needs, whether it's a child, an adult, an elderly person with conditions that Dr. Nafula has mentioned. So in developed countries, hospices are actually limited to the last 6 months of life. But in Kenya, where we are, a hospice provides palliative care services for these patients, which is basically taking care of their symptoms if they have, whether they are physical symptoms, whether they're emotional, psychological, social issues. So in Kenya, we have hospices which are like, they're health facilities actually, located in different counties in Kenya, where you have palliative care providers who have studied palliative care. They'll take care of their needs based on based on the needs at that time. They can also be provided for this care within a hospital. So like Kenyatta has a palliative care unit where when a patient goes for example, they have a diagnosis of cancer, they're being seen by the oncologist, but they're also receiving the services in the palliative care unit with Dr. Nafula, or at the Nairobi hospice, which is just next to the hospital, where they're also able to see the patient at home. So there's home-based care, there's facility-based care.
Okay. Maybe you can, maybe debunk this, maybe a myth, but we've heard, so there's palliative care, which is, from what you've said, undertaken at a hospice. Can be.
Yes.
Right?
Sure.
But oftentimes we think that it is only for conditions or diseases whereby there is nothing that can be done medically anymore. Is that the case? And if not, then can you separate those two for us? Because we often believe, I think, or we've heard, that those who are under palliative care,
end stage,
are end stage patients.
Essentially, a terminally ill.
Terminally ill patients are those who are now receiving palliative care. Try to make you comfortable because there's nothing more that can be done. Is that true?
So actually, that was the past thinking, but where we are now, we offer palliative care services from the point of diagnosis. So if I have a condition that is life-threatening or life-limiting, or as Dr. Nafula has highlighted, anything that is going to change the way I've been living, it's not something that I'll get cured tomorrow. So it's not like malaria, you're assured of a cure. If I have maybe organ failure, for example, I would have a palliative care specialist working with me this journey, together with it's the internal medicine consultant, if it's the chest specialist. So we are offering palliative care for this patient. That is just taking care of their symptoms, taking care of their worries, as this other practitioner also does the specific management. So if I was to go back to the example of cancer, a patient going to the cancer center will be getting their radiotherapy or chemotherapy, as the palliative care team takes care of their symptoms, the pain, the psychological issues, among many other things. So basically from the point of diagnosis and not really giving up, but it continues up to the end of life. Okay. So if you get to end of life, now where death is imminent, the care still continues. It's just that now the palliative care takes more center stage, and the curative treatments are now reduced.
Can you give palliative care for somebody who does not have a terminal illness condition?
We wouldn't call them terminal. Well, terminal is one of them, is one of the inclusive criteria, but you are looking at anything that is causing serious health suffering.
Okay.
I would put it that way.
Okay.
So, for example, a patient who has had a diagnosis of COVID sounded really simple, but then now they've had to go to ICU, they've had complications. Palliative care really helps them too, because you're not just looking at the COVID, but you're looking at the person in totality. So palliative care, I would say, is a type of care that looks at the person in totality and not just at the disease the person has. Yes.
Okay.
And maybe I can chip in. Palliative care as a movement started in 1960s, but before then people were still receiving palliative care. If you look at the history of our communities back home, people were taking care of dying patients, and they would focus not just on the fact that someone is dying, but they would want to know, whom do you want to talk to? How can we help you through this process? So in the 1800s, hospice care was started by the Catholic Church. Mostly it was being offered to poor dying patients by the church as part of mission, especially the Catholic Church. So around the 1960s, the pioneer doctors who took up palliative care, one was a psychiatrist, Dr. Kubler-Ross. The other one was a urologist, Professor Belfort-Mount, and they were working a lot with cancer patients. But again, a lot of studies they did was among dying cancer patients. So it started off as hospice care, that we are taking care of dying patients. But with time, these interventions are needed not just for a dying person, but anyone who has a serious medical condition. Take a child who is born with a heart problem. Some of these children will live up to adulthood, but with a lot of suffering because they have pain. Their life is not going to be normal like another child. They're not going to be out playing and developing like you would expect a normal child to develop. So such children also need palliative care, because what we do, there is the medical management where we will take care of your diagnosis, but then there is the communication. How does the family handle this child? What do they talk about? How do they make plans for the future? So those are some of the things that we do when we're giving palliative care. So end of life is part of it, but it's not the only thing that we do for patients.
So essentially, the entire process is incomplete if the family is not involved.
Exactly.
Now, when you look at the flow of patients who come for the services that are offered in the part of the hospital that you work in, do you see the numbers increasing? And if you see the numbers increasing, and we're talking about pain, what exhibits as the most common cause of the pains that people come with? And beyond relief, do you find that it is possible to eliminate the pain completely? And if so, in what sort of pain? Caused by what specifically?
So in my practice, I've been working in this field now about 7 years. And I would say the common cause of pain is actually psychological and spiritual pain. So patients do come with pain and they say, my tummy hurts. But when you sit with them and discuss with them, a lot of their pain burden is because of maybe the social isolation that they're facing at home. So someone is sick and their family only interacts with them maybe 1 hour. Typically when someone comes to visit a sick person, they stay in the sitting room with relatives, and then when they're leaving, they pass by the bedroom to say hi to the sick person and then leave. Sick people, like elderly people, you find that their children have taken over, making all decisions. They've taken over their finances. So that is what even increases the physical pain. Because someone is sick, their life has changed. They are not independent anymore. They have to depend on their family. But this same family is isolating them from decision making. You find someone has been bundled on a plane to go to India. Nobody consulted them.
They were not aware that they are going to
India. What kind of treatment do you want? What do you wish for yourself now that you're not able to make decisions? So that is one of the biggest causes of pain.
Or they've determined this person can't make decisions.
Yes. But without
involving
really,
them.
Yes.
Without public participation.
Yes. Even when they come to hospital, they want to speak on behalf of the patient and tell you that my father has a swollen abdomen, he's not feeding, his appetite is poor, yet your father is seated right there and he can speak for himself. So a lot of the physical pain is worsened by the emotional pain. Then spiritual issues come into play. Someone is sick, you find you've been a pastor all your life, you dedicated your life to serving God, then now you're 80 and you get sick. And we are telling you cannot be cured. So this person decides, I'm no longer interested in church, but the family is coming now, we want to pray for you. So we don't really pay attention, to the needs of the patient. So as much as we give them a prescription of painkillers, sometimes the pain goes away just by talking and getting people to understand how to support the patient versus just giving you a prescription, go and take this medication 3 times in a day.
Anecdotally speaking,
yes,
what percentage of patients fall into this category of people who have psychosomatic issues?
I would go with 7 out of 10. So they always have physical pain, yes, that we will manage, but without managing the other social, psychological problems, we are not able, the painkillers will not work. And because there is a lot of anxiety.
And you say it's on the increase.
Yes.
Okay.
So what causes? Is it that Because clearly the family members all care for you.
Yes.
And they care for you deeply. And that's why they are doing all these things. They're involved. They have taken your disease to be theirs. And what they think they're doing is they're taking away the burden.
Yes.
So you just deal with the physical pain. We will deal with all the other pains and all the other burdens. Now, if you come and tell the family, okay, no, you need to involve him, how do you do that? How do you actually make them understand that this person can still shoulder the heavy burden? Because you see, this is the same person who's telling you, you guys, no, India, so...
Eric, this is the person who brought you up.
Yeah.
Okay? This person who now you don't want to consult.
So,
but
you see,
you got to where you are.
At some point, there will be public participation, but you will see this patient almost getting to the point of giving up. This is a person who will start telling you, you guys, no, the India. He's already thinking, India, how much does it cost? Now, these are my children. Am I now going to start being a bother to them and start, even affecting their own livelihoods by them taking me through this? So this person is basically trying to push back and saying, I don't want to be in this hospital. You people have brought me into a very big room. Can't you just take me home? Because the person is actually, what they're thinking about is the bill that he's incurring while he's here. And he knows his money is not paying this bill.
I mean, he hasn't stopped being a parent.
He hasn't stopped being a parent.
He's
so
still
he's
caring for his...
Yes.
And you now as the children are caring and saying, no, we will give our dad, our mom the best care that we can afford. We will do everything. We will break our backs. We will sell little that we have to make sure that our father gets the best care because he brought us up. Our mother does this. Is that conflict? How do you balance that conflict?
So, as we've emphasized, palliative care is about the patient and the family, but the patient comes first, then the family comes second. So, we have to assess a patient and understand what are your needs as a patient. Even if I have pain, my biggest priority might just be to get out of bed, not to get cured. So, we have to understand how to support the patient. So, the family comes in to support the patient. So we start by assessing the patient, understanding their needs. Even if it's a child, we ask for consent. Please allow us to have a session with your child, understand what they're going through because they're the ones who are sick. Then we do have what we call family conferences where we call the family members and the patients guide us to know who are the important family members or the decision makers in the family. And we organize meetings. Sometimes it's one meeting, sometimes it is several meetings. But those meetings, the agenda is usually first to discuss the diagnosis, treatment options, then the prognosis, what is the likely outcome of this disease. Okay. And then as the medical team, what kind of care are we recommending? Then now, what does the patient wish? For example, even if you want to take someone to India, does the patient wish to actually get a second opinion, be it in Kenya or outside the country? So that's where we start from, to establish what the goals are, what the goals of care are, and then to help the patient and family come to a good decision. Because we've seen patients who go out, but they come back in caskets, or they go out, they spend all their resources and they're told this disease is incurable. So they are back to us to receive palliative care in Kenya. So we try to help the patient and the family to make the decision that is best for everyone. At that time. But the center has to be the patient. Yes.
Let's take a break. It's 28 minutes to 10. This Health Friday conversation is about hospice and palliative care, and we're joined by two experts. Dr. Esther Muinga is a special coordinator for pain relief and palliative care at the Kenya Hospice and Palliative Care Association, KAPCA. The H is silent. Dr. Esther Nafula is a palliative care and pain management specialist at the Kenyatta National Hospital. The H is not silent. It's KNH. Spice. We have two experts, Dr. Esther Muinga, a special coordinator for pain relief and palliative care at the Kenya Hospital and Hospice and Palliative Care. Hey,
you just want to let him say hospital.
And then there is from Kenyatta National Hospital,
Yes.
Dr. Esther Nafula, palliative care and pain management specialist. So we, in our healthcare system, from level 1 to level 6, right? There's all those things and the cares that are available at each level and each stage. And then we have maternity, we have all these other specialist sides. Is hospice part of actually recognized stage in our healthcare system? And at what stage? What hospital offers hospice and palliative care? Is it stage level 3, level 4, level 6?
When we go back to the word palliative care, because that's the actual service being provided, palliative care should be available to the community level. So that means from level 1 to level 6, where Kenyatta lies. So as someone establishes a hospice, in Kenya, hospices are community-owned institutions or health facilities located within different counties. So it would still be registered at an appropriate level based on the services you provide. So there are some hospices that will just be doing home-based care. So that's reaching to level 1, 2. There are hospices that are offering inpatient care. So that's a bigger level facility. So it could go up to level 4, 5. There are palliative care services in level 6 facilities, so like Kenyatta National Hospital. So palliative care really cuts across level 1 to level 6. But in terms of establishment of the standalone centers, the registration would depend on how the Kenya Medical and Practitioners Dentist Council accredits you and what services you're offering, as well as the number of staff you're offering.
Does the government healthcare system establish palliative care and facilities across all these levels? Because government builds a maternity.
Yes.
Does government build hospices?
So far, government has not built hospices per se, but government has, the Ministry of Health has a palliative care policy that was launched in 2021, which was the first policy that actually recommends that these services should be available across all counties for all patients in need. So what government is encouraging is integration of these services, because we talk about palliative care cutting across different disease conditions, different age groups and age sets. So palliative care is one of the key services hospitals should be providing. Just the way you mentioned, there's maternity.
And mortuary.
And mortuary.
Yes.
Yes, there's palliative care. Like, you have to have a palliative care service within your facility.
So why don't they?
But so far, there's none that is built by government.
No,
It's integrated.
it's integrated care. Yes.
Just explain to
you
us how
see,
it's integrated.
yes.
Yes.
So what integration means is that part of the services being offered in a government facility include palliative care.
Okay.
So if we look at KNH, Moi Referral, and the level 5 hospitals, which used to be provincial hospitals, now they are county hospitals. So the government has given provision for palliative care services in these facilities. So we have staff who are offering palliative care, and we have rooms and times dedicated for palliative care. So that's what integration means, that instead of saying we are building a new
standalone unit
center for palliative care, it becomes part of the services being offered within the healthcare system.
Only that it's right now restricted to PGHs and KNH, KUTTRH.
The biggest problem, I think the biggest challenge is skilled staff, because you need skilled staff to provide palliative care.
Sure.
So we do have a shortage of skilled staff in the country to provide palliative care.
So then does it become part of the prescription for care? And I think that because then, if already in the back of your mind, you know that it's going to be a service of staff and there are only certain rooms, the likelihood of then it being on the list of things that a patient ought to do then reduces, doesn't it? Because if it's not widely available, it's not going to be one of the things that you prescribe unless you make a suggestion to somebody. Whereas, for example, if you know that somebody broke their foot, right, and they've come off the plaster, physiotherapy is one of the things that they will do in the treatment plan, isn't it?
Yes.
But here with palliative care, you know that it's going to be necessary at some point, but you will not be as readily excited
Yeah.
to say
But
palliative comes in,
there've
isn't
been
it?
a lot of milestones
Yeah.
because in like 2007, there were only 14 centers providing palliative care
Okay.
for the whole of Kenya.
Kenya.
Today, there are about 105 facilities.
Okay.
And these facilities, remember, in government hospitals, are in mission facilities, are in private hospitals, are in standalone hospices. So when we refer back to the term hospice in Kenya, because it's like a community. So for example, Spice FM would come together and say, we are setting up a hospice that is only providing
Hospice.
palliative care services, palliative care services located at this center. The palliative care units within the other facilities where we are talking about integration would be providing you this service. As you walk in, you're going to physiotherapy, you're going to palliative care department.
Yes.
The hospice one, standalone, is just the way you'll see, for example, there's a maternity hospital set up just for that. So someone is at liberty to put that up, providing specialized care. So there could be specialist facilities, but there is the integration, which is what we recommend, because you want a patient to get all services at one place.
Okay.
Yes.
At what, and this may be taking us back a little bit, but just at what point then would you say it would be necessary, Dr. for a patient and their family to consider palliative care? I mean, I understand the encouragement around and saying, okay, this is, you shouldn't travel or you should travel, blah. But at what point do you say, okay, this is the direction that you should be going in? It would not be an easy conversation to have, I can imagine. But then how do you say, okay, it is at this point that we need to then introduce the option of palliative care for someone?
So what we're encouraging, there's something we call disease trajectory. So from the time of diagnosis, you can predict the natural course of this illness. For example, if someone has malaria, we can predict that in 3 days, if we've not given you treatment, your liver is going to fail. So we need to treat this malaria, and within 1 week, you'll be off treatment. So at the time when a diagnosis is made, there are some illnesses that are likely to result in a lot of suffering.
Okay.
Or they need a lot of care and a lot of involvement and a lot of resources. So the current advocacy is that at the time when this diagnosis is made is the time when a patient should be referred to palliative care.
Okay.
I'll give you an example. In Kenyatta, we've managed for the children's wards, when a child comes in and they have a diagnosis of a congenital illness or a disease like sickle cell or cancer, those children are referred to palliative care. At that time, they might not need us to manage any pain or any symptoms, but what they need is information. So we sit down with the parents, talk about the disease, the treatment, what to expect. So in the event that the child is treated and they get well, it's good.
Okay.
In case they complicate, the family is already on board and they understand what interventions palliative care is coming to add.
Okay.
The word palliate itself actually means to cloak or to cover.
To cover.
So it is sort of an extra layer of support that we give to patients and families.
So would a doctor, for example, and let's just take a cancer patient as an example.
Yes.
So you have your oncologist who's dealing with this patient, right?
Yeah.
Would that doctor at that point, having seen the trajectory that you speak of, then come along with a palliative specialist, kind of like a woman who's going into labor? The pediatrician is there.
Yes.
The obstetrician is there. There's somebody else in the room, I can't remember. But those people are all there, they come together.
The one for injecting you to sleep.
So in this case,
Yes.
would now that doctor then say, this care now needs to be extended and we bring in the specialist and let's go into this together?
That is actually the correct way to
100%.
offer palliative care, and that's where a lot of the world is moving to as the practice of palliative care is evolving. That's where we are moving to. I think during COVID times we had a lot of palliative care being offered to patients with COVID, And the common question I got is, why are these patients receiving palliative care? But it's about understanding what interventions actually are involved and can benefit this patient.
Right.
Yes.
From everything that you've heard you mention and describe the palliative care, sounds like counseling.
No. Counseling is part of it. Counseling is part of it.
What are the other components?
So I could break it down. First, there's symptom management. So we look at the illness that the patient has. That's why palliative care is offered as a team. So you have a doctor, palliative care expert, to take care of your medical diagnosis, your treatments, scans, tests that are needed. Then you have nurses. Nurses will take care of the daily care of the patient.
Okay.
Then you have now the psychological bit. As a doctor, I might not be able to counsel someone. I might just give them information about their diagnosis, treatment, and help them to make a decision about their care. But now when it comes to psychology, we need a psychologist now to sit with you and help you to know how to cope with your illness. Then we have the spiritual leaders or chaplains that also help us with the existential issues.
City is smiling.
Yes.
So you now, Dr. Nafula,
Yes.
you're a palliative care and pain management specialist.
Yes.
What do you do, you now, you Wewe?
So
At
me,
KNH?
yes.
Beyond praying for your patients.
He was not going to let
I know. I don't pray for them. So what I do is to assess the patient. So if a patient has come in pain or with a diagnosis that needs palliative care, so my biggest role is to assess and give a treatment plan. That this, for example, someone has had a stroke, so we are going to treat the stroke with this medication. This is the kind of support that this patient needs. Then now we identify the team that needs to support the patient. So if the patient needs any scans done, any medications changed, that would be my work.
But I thought you said that there's going to be a specialist. So if it's cancer, there's going to be a cancer specialist.
So we work together.
And the cancer specialist then is dealing with those things of knowing what kind of medication that they need. So what will you be doing?
I'll prescribe the painkillers, for example. I will
the
ensure
pain
this
side.
patient is not getting clots because they're bedridden. Yeah, so the medical care of that patient.
Okay.
Yes. But we work together with the primary physicians. Then at some point, as Dr. Esther explained, there gets to a point where the primary physician feels that we are not adding role to the care of this patient. We are not adding value because maybe we are no longer giving active treatment to manage the disease.
Yeah.
So that patient is handed over now to palliative care. But you see, there's still a disease and there's still medical things that need to be managed that now I would do.
Oh.
Yes. Yeah.
How much does this cost?
In terms of the service itself, we've had an outline of what is actually involved. Yeah. So if you're talking about symptom management, you're looking at the review done by the healthcare team. There's the cost of the medications that will be prescribed. So that would depend on what is actually written on the prescription pad. If they need physiotherapist intervention, that's a separate cost. So when you're talking of palliative care, because it's multidisciplinary, that means there are many experts coming in to take care of this patient's needs. The fees actually depend on what actual services you're getting. But for example, if someone was to walk into Nairobi hospice, they require palliative care services. They'd normally be the fees that you pay to open a file, then a consultation fee. So the rest of the charges would really depend on your needs, the needs of that patient at that time. And I would say it's quite affordable because the medications that we are prescribing would be things that the hospital or the healthcare system already lists in our essential medicines list. And the other bit is that if someone has the National Health Insurance, NHIF, you'd use that for your outpatient service or inpatient service. So outpatient, depending on the facility you've chosen. Inpatient, if someone is admitted at Kenyatta, they would use their card for that. Yeah.
So it's covered. So it doesn't fall under. Would you? Because I can imagine now it being that kind of service that your insurance provider would tell you that it is pre-existing condition. That's language that's
nonsense.
the nonsense that we are told about it being a pre-existing condition and etc. etc.
Yeah.
But then would insurance cover this? Because from this entire conversation, it is clear that at some point it is necessary to have this care. It is not cosmetic,
Yes.
So insurance in this country, is it covering palliative care?
I would say it is, because the only challenge that we've seen patients coming back with is because NHIF, I'll speak on behalf for NHIF, because for outpatient services, you'd have to select a facility. So the card is only viable in facility X. Inpatient services, depending on the category of cover you've taken, you'd receive those services where you are admitted. In terms of the medications, as long as they're available within the facility, someone would still be able to use their card for those services. And I think Dr. Nafula has been using NHIF in Kenyatta.
But for private insurances, your diagnosis has to be covered by the insurance for them to pay for palliative care. So if they say it's a pre-existing condition, you have to wait out the waiting period for them to cover any other treatment for that illness, including palliative care.
I have a tough question.
Yes.
Folks who get into palliative care for the time that they do, if you look at the numbers, what is in the majority? Those who make it or those who pass?
That's a tough question, because in hospital, any patient walking through the doors of the hospital can die or survive. So I would not put a percentage to it, because there are patients some patients we follow them up for a long time, some for a short time. And as we said, the interventions include pain management, symptom management, end of life care. So it really depends on what aspect of service the patient is getting. Yes.
But over time, we've seen people living like long times, as she's talking about. So we had the Cancer Survivors Day being celebrated. It's celebrated every first Sunday of June. And there are patients who you'd see talking and saying, I got a diagnosis of cancer, because that one was focusing on cancer in 1980. They're still alive. There are others who got a diagnosis maybe recently, depending on the stage, then they pass on. So studies have actually shown, if you were to give patients palliative care from early in the journey of their illness, you're able to improve their quality of life, because that's the main thing, improving their quality of life. You're able to improve their satisfaction, you're able to improve their coping mechanisms, and they're able also to be compliant with the primary doctor's treatment schedules.
We're getting to the end of the show, but I have to ask this question. Those who offer psychological and spiritual help, how much knowledge do they have of the conditions that they're offering these services for?
So the ones we use, for example, in Kenyatta, we have the whole team. We have a mental health department that has psychologists. So they have to be trained in clinical psychology. So they have been trained in how to deal with reactions that come with illness. They might not have much information about the diagnosis or treatment, but they know how to give psychological interventions. The chaplains we have are clinical chaplains. They've been trained in chaplaincy and spiritual care. So their work is not to pray for patients, but to understand what the spiritual needs of the patients are and what kind of support the patient needs. So we work as a team. So I might identify...
Kazi kuwekelea watu mikono peke yake.
They actually do have... recently I learned that they do have an assessment tool that they use to understand what the spiritual needs are and then prescribe the support. So we work as a team. So where the patient has gone for counseling and the psychologist feels this, you should have a chat with the patient just about diagnosis and treatment. That is where their problem is. They would send back the patient to us. Yes.
Thank you very much for joining us today, doctors. I wanted to get a question in, but there's no time. So that you can just address CT and explain the difference between hospice and what was it?
Care.
No.
Old people's homes.
Warehouses.
Warehouses.
The difference between a hospice and a warehouse. But that's for next time. Thank you very much for joining us. Dr. Esther Muinga is a special coordinator for pain relief and palliative care at the Kenya Hospice and Palliative Care Association. I got it right.
Yes,
right?
correct.
Right.
Well done.
Dr. Esther Nafula is a palliative care and pain management specialist at the Kenyatta National Hospital. You know, CT is only one of 5 people from his village who can say hospital.
5.
Enjoy your weekend, people. Have a lovely one. Go to Sarit Center as they celebrate and commemorate 40 years of their existence. Sarit, your city. Good morning. It's 10 a.m.
This is the Situation Room, the only way to start your day.